going to start on time, but we still have.
And for you, sir, we have something money cannot buy. A solid chocolate casket. You've got to know somebody at Batesville Casket to do that. I will tell you, Batesville Casket has some really good epidemiologists. They have to custom make a casket that goes 60 miles outside of Kearney in 3 days. And they've got to know a lot about logistics, but a lot about epidemiology, how the flu is going to work. I'm going to meet with them about coronavirus. with you more about failures, the things I've seen in rural healthcare. I'm the past president of the National Rural Health Association, Indiana Rural Health Association, things of that nature. So I've got a perspective beyond my hospital. So some of the things I'll share with you are what happened in my hospital and what's happened nationally. And sadly, it's more about what I've learned through failure than success. As you guys start your careers, and some of you have been in them, you know what I mean by that. Basics on the folks that live in rural America. They are older, sicker, and poorer. That's pretty much a standard. You kind of look at that, the average age is much older, and life expectancy is a big deal. There's a 2-year life expectancy, 2 to 2.5 year life expectancy if you live in a rural area versus an urban area. Now, when you think about that 2-year life expectancy, don't think about the 2 years in the nursing home. 2 years you take out of the middle of your life, the most active part. When you look at some rural counties in Appalachia and eastern Kentucky, the life expectancy is 70 years. When you look at the entire, and this is for the entire county, rich and poor alike. When you look at it in Marin County in California or Fairfax County in Virginia, it's almost 14 years longer. 14 years of the middle, most productive years of your life. And that's kind of what's happening. And I think there's a lot of reasons to that. We see a lot of differences that happen. One thing has to do with fruits and vegetables. We used to grow those in rural areas. And now you see fewer people canning, fewer people freezing, fewer people having gardens. The local grocery store has been replaced by the convenience store and the Dollar General store. Try and get fresh fruits and vegetables in rural America these days. Many times the only restaurant in a lot of small towns is a McDonald's if you can get it. And that's kind of what we're having. So there's a lot of things happening. It's a sedentary life compared to what used to be an active life. So there's a lot of things changing in rural America and creating a lot of problems. So, and rural healthcare is struggling with this as well. The big challenge we get is the closure of rural hospitals. Every 3 weeks in this country, one rural hospital will close. And pretty much half the time leave nothing in its wake because the hospital employ the physicians, employ the technicians, employ the nurses. When the hospital goes, then the only thing left is local EMS service. But the thing that concerns me the most is not the death or the closure. People that study the statistics always use that one because it's a binary, it's a 1 or a 0. It's not the death, and many of you that have done your rotations in the medical field realize it's not the death of the patient that's so devastating, it's the dying. It's the when they move from an active life to one that is bedridden or no longer active. And that's what's happened to many of our hospitals. Even though once every 3 weeks one closes, many are cutting their OB services, cutting necessary services just to survive. And that seems to be the thing that bothers me the most, because once you start doing that, there's no ability to come back from that, or your ability to come back from that is very limited. So you cut things like your hospice service, your cardiac rehab, things that are necessary, but you simply just can no longer afford to have it. Critical access hospitals are an interesting thing. They came into being in the late 90s as a rule or law from the federal government that basically, and 1,300 of the rural hospitals in America are critical access. So you look at that 4,000 to 5,000 number of hospitals in the country, 1,300 are critical access or are deemed critical to the communities they serve. By law, they are paid 101% of allowable cost. Now, there's been 2 rounds of sequester, which has cut them by 1% each. And there's a lot of things that are necessary but not allowable. Necessary things like hospice programs, home health programs, the cafeteria, legal fees, marketing fees, none of which are allowable. So the average critical access hospital loses 10% on their Medicare patients. Much more on their Medicaid patients. And you know what? We're happy with that. Because without this designation, we lose 20%. And that's kind of what's happening at this point in time. So people have described the critical access designation as kind of a leaky life raft. It sort of can keep you going, but it's not really stable, it's not really solid. One thing that I need people to realize is, anybody have a farm background? Okay, I love Nebraska. You guys know what I'm talking about here. A lot of family farms have folded. A lot of family farms still struggle today. One of the best advice I got is from a farmer who was a board member, Bill Staker, and he told me, he said, you know, it ain't about farming anymore. He said it's about adapting to whatever weird government program is out there. It's not about providing better health care or getting payments for doing what you do better as much as it is adapting to different things that the federal government has put in place. One great example is the opioid epidemic that's going on. And you'll hear politicians talk about this as a big deal, and this is what we've got to do to address it. But the funding for treatment of patients doesn't increase. What you hear is grant money. We funded grants for this and grants for that and everything like that. Hospitals run on being paid for treatment of patients, not grants. If we want to be able to survive, we've got to adapt to whatever, even if a grant makes no sense whatsoever, we've got to be able to adapt to that. It's a shame. You'd like to get paid, farmers would like to get paid a fair price for their product, but if you don't adapt to whatever the government program is, in the words of my board member, Bill Staker, you ain't farming anymore. The other programs that are out there that you kind of want to sort of look at, rural health clinics, federal qualified health centers, global payment models. There's a model that was in, and this is interesting, it sort of works in rural health care, that if you go into Pennsylvania, they'll go into a small community and say, look, what were you paid for services last year? All the billing you did, all the influenza vaccines you gave, all the surgeries you did, all the therapy you did, how much were you paid and by which payers? So Medicare, Medicaid, all the commercial insurance is $15 million, $20 million, whatever it is. All right, we'll gather them up and we'll pay you that. Now you take care of your community. How do we change healthcare delivery by doing that? You don't have to bill for every injection you give or anything like that. Now we talk about how do we make the health of the community better? And that's kind of the mission statement of many of the hospitals. How do we improve the health of our communities? So it's a really interesting discussion that you start having. How do we prevent people from calling 911? When the ambulance shows up, do they have to transport the patient to get paid, or can we do something else? Can we give them a breathing treatment and get them right to the doctor's office the next morning? How serious are we about falls? I'll talk to physicians. How many patients have falls? Or how are at risk of falls? They all raise their hands up. Is their home safe for someone that's at risk of falls? I don't know. I've never been there, because we don't get paid to be there. We don't get paid to go there. But is that the best for the patient? Is that what we should be doing in a perfect world? And the answer is yes. So that's the kind of thing that when you get into these weird payment programs, and well, look at the Pennsylvania global payment model, that's interesting. The other thing is Medicare for all. This is a capitalism lecture. Is that part of this? Alan, is that the...
You can be for...
Yeah. Okay, all right. So one of the things is when you look at the mission of our institutions, it's how do we improve the health of our communities. And right now, I have gone, 10 years ago, I used to get paid by like 5 or 6 insurance companies, Medicare, Medicaid, and things like that. Now that number is close to 100. Every insurance company is split off into 3 or 4 different things. They've got 4 or 5 different programs for each one of the Medicaid programs that I'm on. I've got so many Medicare Advantage things. With Medicare for all, I know I'm going to get jerked around by Medicare. But sometimes I think I'd rather be jerked around by one group than jerked around by 100. A lot of things we deal with, like surprise billing in healthcare, many times that ends up being an issue of the patient will come in, well, I've got good insurance, but it doesn't cover this. You know, the answer is, you don't have good insurance. People don't have good coverage, and they're surprised when their coverage doesn't pay for this. Or they go in and, well, I went to this hospital thinking that you were all together and on one network and things of that nature, and we're not. And many times you look at me as the hospital, okay, well, a doctor that has independent privileges that practices here is not part of that network. I'm sorry, there's not much I can do about it. But this fragmentation and differentiation of insurance is really difficult. I talk to someone, well, I don't trust the government, and I think the rules are going to be crazy. And I'm like, great. At least they're a crazy set of rules. I mean, you may not like the rules in football, but at least you know what they are. You don't prepare your team to go out and play football, and all of a sudden the other team's putting on ice skates and walking out there with a puck. That's kind of what's happening in healthcare right now. So I don't know what's going to end up happening with it. There's a lot of opinions. What I don't think is happening well with the Medicare for All debate is the fact that there's not a debate. There are people screaming at each other. We're not having a good discussion about it. But a lot of stuff is coming to a head. There's no tolerance for continuing how we are. I just don't want rural healthcare to be lost in that. Back to rural healthcare. One of the biggest things that hospitals have to do to be able to be successful, and you as providers have to be successful in rural areas, gain the trust of your community. You walk into the guys in the corner of wherever they drink coffee in the morning, and every town has one. You walk in there and say, your local hospital sucks, and see what you get. Do you get people jumping on that bandwagon? You're right, everybody that can goes 50 miles down the road to someplace else. Or do you get, my niece works there and she really does a good job. The hospital CEO is an idiot, but my niece is really good and she's really trying to take care of patients, and I know she cares about what she's doing. So some of it's how much we're part of it, how much we are part of the communities that we serve. What does it take to gain that level of trust? When I was in a hospital in Illinois, the very first thing I go in and do, the county was in charge of local EMS and the ambulances and things like that. The EMS service gives a 60-day notice. We're leaving the county. We can't stay here. And we're sitting there going, oh my gosh. So all the fire department guys come together and the county officials come together, and I'm like a week into the job and sat down at the hospital. One of the fire chiefs standing there said, I wouldn't take a dead dog to your hospital. Whatever ambulance service we have, I want them to take everybody out of town. I'm like, okay, well, hi, nice to meet you. I'm the new guy, and I ain't from around here, or I ain't from around these parts, depending on where you come from. But one thing I learned as a leader in a rural area is you stand there and you take it. Whatever they're shoveling out, whatever they're angry about was because somebody in their family wasn't treated right, or their mom died at that hospital and they just can't drive by there anymore, or anything like that. You stand and you take it. We're here, our mission's the same, and after that I had 30 people come up and apologize that that's not right. We know there's been some problems, but we want to work with you to make them better. So you stand there and you just work through that and you take it. I have so many people come into my community and say they want to be part of the community. We want to be part of your community. And part of my community doesn't mean taking an ad out in the yearbook. It doesn't mean, sponsoring something on the radio station or having a float in the parade. It means that you are part of the community. You laugh with us, you cry with us. It's not as much about going to football games and basketball games on Friday nights as it is going to funerals and being part of that. You live with them, you die with them, you hurt with them, and you celebrate with them. And that really is what I think a lot of rural hospitals or a lot of rural healthcare providers do. Some of them don't want to be a community. I will tell you, I had an example where I had a group of pediatricians that were in town, but they were employed by a hospital out of town. And they covered my nursery. Keep in mind, I'm delivering 500 babies a year. So they are covering my nursery for the one call a week they get when something's not quite right with a newborn. And they came to me in unison and said, we're not going to cover the nursery anymore, because we think pediatricians being on call is an unsustainable model and is not best for our hospital, which is 60 miles away. And I'm sitting there going, you get one call a week. There's 5 of you. You have to come in to this institution 9 times a year on call, and that's unsustainable? And their answer is, yep, we're officially dropping our privileges. And I had to build a call system with my primary care docs and recruit docs in to be able to do that. But that's someone that doesn't want to be part of your community. That's someone that's willing to take care of patients, but they don't want to be part of your community. And we need people to be part of the community. They need to, and that's one of the things, if you're in a small town, okay, anonymity doesn't exist. But it's awesome. You get to know people and get a chance to make a difference for people that you care about. And if you want anonymity, then you really need to be working in a large city. and not take from it. So I don't mind people doing that. That's fantastic. But the issue is, how do you make a difference in a rural community? And you have to do that. You have to be part of it to really make a difference. A lot of times, I think we function as hunter-gatherers. Does anybody recognize this? Okay. All right, northern exposure. All right, everybody's got the Brooklyn to Batesville kind of model, where we've recruited this, and we're hunter-gatherers. We look for the physician to come in from out of town and come in and be the doc in town. I think we need to move to agrarian. I think, and it's a long, it's not like growing corn and beans. This is growing an orchard. This takes a while. We've got a program in our community that is really interesting that I haven't shared with our attorneys. Don't want to have that conversation, but we bring high school students. They're in a block schedule, so 2 days a week they get this 2.5 to 3 hour block for an entire semester to come into the hospital. And they come into surgery, ER, obstetrics, wound clinic, physical therapy, and see what it's like to be at the hospital. And 100% want to be in healthcare when they go into that. 80% still want to be in healthcare when they come out of it. 20% are like, ooh, ick. I don't want anything to do with that, and now I know it. But we've created this pipeline. So when I'm bringing a junior in high school into this program that's really learning that healthcare is not like Grey's Anatomy. That's their biggest learning thing. That's number one. Oh, the hospital is not like Grey's Anatomy. Okay. And we have to realize that's the big deal going in. But then they kind of learn what's cool, what they really like. They really like ER. They really like seeing babies be born. That's my real indicator. If they get into OB and they happen to see a delivery or a C-section, if they get through that, hey, they're golden. They're good to go. But they get that practical experience. They can't take advanced chemistry and biology classes in our small town, but what they can do is get that practical experience. Now, what I get is this pipeline that after 6 or 7 years, they come back. Hopefully, many of them do. And I've got 3 or 4 nurses already that have done that program and come back and are working in our institution and know why. I knew what they were getting into. But what I really get out of it is when the parents ask, okay, what did you learn at school today? And part of it, they can't tell them. So I'm getting between a 17-year-old and their parents because they saw somebody they knew at the hospital and can't say a word. Little scary place to be from a hospital administrator standpoint. But one of the things that's really neat about it is they get this interest. I want to be in healthcare or I don't want to be in healthcare, but now they're thinking about a career. And the parents are thinking about 2 things. Primarily when the kids get excited about this. 1, there's a strong possibility they won't be living in my basement in 5 years. And 2, the grandkids might be around here because that's a career they might be able to have in this hometown. So all of a sudden, the guys at the coffee shop that were kind of angry or snippy at the hospital, when the kids get together or their family gets together and they've got good things to say about what they experienced there, that's a really positive thing for me. So. Another thing, and this comes into an issue with that a lot of my physicians and nurses, they want to be married. They're weird about this. They date or something. And one thing we have to realize in rural areas is I don't have jobs for other spouses. First of all you guys that are nurses, pre-med or whatever it is, date elementary school teachers. Got jobs for those people. No problem whatsoever. Chemical engineers, stay away from them. You don't want to be around those people. That's kind of what you have to kind of sort of realize. That's one of the things. We are who we are. You want to be in casket design? I got jobs for you in Batesville. Epidemiology? Yeah, I've got those people too. Marketing and fashion design? Things of that nature, I don't have those. So when I'm recruiting someone to be in leadership or frontline nursing or therapy or something of that nature, what their spouse does, the spouse has to be underemployed. Now, whether that means they're a chemical engineer and they teach chemistry at the high school, or they drive 60 miles to a job, or they telecommute, they're not going to be in the career path they want. And you kind of have to realize that. I don't have an answer for that, just a realization. Okay, I hate to break it to you. People talk about the U.S. healthcare system. It doesn't exist. There really isn't one. However, there's no shortage of good people doing good work. That's kind of what happens, but you get in with a critical access hospital or some small rural clinic or something like, we're pretty self-aware of what we can do and what we can't do. This is who we are, so we need to make partnerships. We need to work with people. And in small communities, you kind of realize you have to work with people. You have to know your friends and neighbors. You have to know the capability of the nursing homes. You have to be able to understand that when your patient has severe cardiac issue, neurological issue, you can't take place with it. And my thing is, I need to build those bridges before I need them. I need to be able to make sure that patient gets the care they need, and it's not duplicated someplace else, and it's not really for us. One of the things that we had that was a real eye-opener to me is when we had our ambulance pick up a patient and come in and call in, hey, I've got a patient with a cardiac arrest, it's a STEMI, you need to be able to get this patient out of here because we need that patient to go to the surgery or into a cath lab. We don't have the capabilities at our hospital. So we do everything, okay, bring the patient here, we'll run the labs, we'll run all the tests, we'll run our EKG ourselves, and holy smoke, this patient's having a STEMI, an ST elevation myocardial infarction. We need to get him to the cath lab. So the nurse is on the phone calling up the helicopter. Do you have an accepting hospital? No, we don't. But the doc's working on it. So the doctor and the cardiologist, doctor in the ER and the cardiologist playing phone tag back and forth. Hey, we've got a cardiologist. Okay, will you accept this patient? They've got on a 12 lead, they've got a STEMI. Yeah, okay, now you can send the helicopter. Now the helicopter can come in, take the patient to the tertiary care hospital where they repeat everything we've done. Hey, this patient really does have a STEMI. Let's call in the cath lab team. The cath lab team comes in and takes care of the patient. Hour and hour and hour went by for that patient with an acute heart attack. We end up working with one of our tertiaries and said, all right, if our folks identify a STEMI in the field, will you notify your cath team and get them on there and guarantee an acceptance? And they said, well, we've got to train all your people to make sure that STEMI means the same thing to us as it means to you. And we did, and they agreed to it, and now there's this thing called door to balloon time when a patient comes in an acute heart attack of how long it takes between when they enter your door to when they get treated in the cath lab and the balloon's inflated. Basically, the goal of that is 90 minutes. Our average has been 110 minutes, but our cath lab is 50 miles away. So we think we're rocking at that. But that's the kind of stuff you've got to do. It's not about what happens in your hospital, it's about how these partnerships you can make. One thing that I think we need to realize and just need to be aware in rural areas, if it's not at the bedside, if you don't need to have it locally, we really need to consider outsourcing. It's a make versus buy. And a lot of this stuff is hitting me hard in the world of IT. And having IT specialists and experts and things like that. In the world of cybersecurity, and I can't get the cybersecurity people that I need, but I need to be able to have access to them. And we just need to be able to realize some of that stuff's coming. For those of you that know about rural or about healthcare and cybersecurity, a lot of people attempt to attack your electronic health records. A hospital down the road from us had theirs attacked because it came through a back door in the CT scanner maintenance channel, and they accessed the entire electronic health record and shut it down and held it hostage. So I've got patients, this hospital had patients going into surgery. They had patients that we don't know their blood type, we don't know what they're being treated for, and we have to go back through manual records. And a friend of mine, CEO, said it was just miserable. They ended up paying the fine, not the fine, the ransom to get their records back. And they hit them on a Friday night before a holiday weekend. So getting everybody there. So I think it's not just what happens in the walls of your hospital. You've got to have people outside. One thing that's happening in rural healthcare and healthcare America is this transition from volume to value. It's right now you get paid to do stuff to people. You do an appendectomy and you get paid for that. You give a flu vaccine shot and you get paid for that. It's getting paid to do stuff to people. And this one is not what we're supposed to be doing. And the best story I have on this is a friend of mine that tried to explain it to me. He said this whole transition from volume to value is about my grandmother. He said, well, when I was little, I used to love to go to my grandma's house, and we'd play, and we'd do everything, and we'd bake cookies together, and it was awesome. And one time I go to my grandma's house, and she's in a wheelchair. And she's in a wheelchair because she had diabetes, which I knew, but I never knew what that meant. But the doctors in the hospital had to cut off her toe. So I couldn't play with my grandma the way I really wanted to. Well, the next time I go and visit my grandma, she's in bed because her diabetes had gotten worse, and they had to cut off her leg. He said, and in the healthcare system today, we're incentivized to diagnose the disease, we're incentivized to cut off the toe, and we're incentivized to cut off the leg because we're paid to do stuff. Now, whether that's done appropriately or not, most likely it's done appropriately. But we're never incentivized to keep my grandma's diabetes under control. And shame on us. We need to be able to do that. So your goal as a hospital is not to be the best toe and foot amputation center in the world. It's to prevent diabetes from progressing. But we don't get paid to do that. And that's what this whole transition from volume to value is all about. How do we prevent that disease from progressing? What do we do? And if you're a hospital today and you work on preventing that disease from progressing, and you're competing against a hospital that's wanting to have the best toe and leg amputation center, you're going to lose to that one. And they're going to get more money and more funding. So the transition from volume to value, I think, is a very important piece, and I think we can do a good job at it in rural healthcare. As a matter of fact, I think we can do better than in urban healthcare. If you're in Denver or Omaha and you're a hospital, you are only getting a fraction of what is happening in your community. But in a rural area of Batesville, man, I'm the game. I don't get everybody. People can leave my community for healthcare, but I've got a population. Some of this is around population health. So how do we improve the health of a population when we've got it? We work with the schools, we work with the city, we work with all these things that can help people become healthier. We have a primary care focus, which is primarily about prevention, not a specialty focus, which is about amputations. Our mindset, when you come into my medical staff meetings and my leadership, it's primary care doctors that are focused on preventing disease and preventing disease from advancing, as opposed to people focused on surgery and subspecialties that you see in an urban environment. I'm not saying they're bad, I'm just saying this is us. This is our wheelhouse, and I think we can do a much better job. When you think about the Pennsylvania global payment model, that discussion can be much stronger in a rural area than it can be in an urban area, where they've just invested millions of dollars in building a state-of-the-art cath lab, as opposed to investing millions of dollars to prevent the progression of heart disease. So. Okay, that's a passionate area of mine. But what we learned, we've been involved in population health, and what we learned through that population health is things are better as a team. It's not about seeing the doctor if you've got diabetes, it's about seeing the doctor, the dietitian, and the pharmacist. How do we work better as a team? Wellness visits. I had a hard time with this. I get my Medicare patients to come into a wellness visit where we sort of look at what you're taking and meet with a care coordinator, nurse, and things of that nature, and what's really going on. And they had a hard time. I don't know why I need to see the doctor. I'm not sick. And it took us a couple of years to get patients, and it's the guys at the corner of the coffee shop, to understand that we can come in, we can keep you being healthy. The biggest thing about this is we looked at this early on. We had patients that were not progressing. You know, we tried to get them to be better, get their hemoglobin A1C under control, or get their breathing treatments under control. So we had an intern that we came in and sent her out to the patients' homes to figure out what was going on, what's really happening. And she'd go out and she'd visit these folks, and very few of them would let her in their home. But when they did, she found out what was going on. One diabetic patient was taking her blood sugar and recording the readings, but she was reading it upside down. She didn't know that the meter was the other way around. One didn't know that you need to exchange the needle, that the stylet, she quit taking her blood sugar because it hurt so much, she had to crank it up so high because she didn't know the needle needed to be replaced. We've got to get into patients' homes to really make a difference, but I think in a rural community, we can do that better. We've got to work with churches and we've got to work with other folks, but I think we can do that better than most. Now, I'll tell you one of the things that is a big deal with this. I used to work in minimally invasive surgery. My background's lasers and optics. If anybody has questions about minimally invasive surgery in the 80s or 90s, let me know. I'm like all your guy. And if you want to know anything about heavy metal vapor lasers, I'm also right there. But one of the things with minimally invasive and some of the laser surgery that was a subtle undertone is the work we did was to try and get bad doctors to have the same outcome as good doctors. We standardized the procedure, we tried to limit it. It wasn't about the quality of the surgeon, it's about the quality of the technique, the process we used. And that's really a big deal that we're trying to do in population health. So as you work with a team and work with protocols, you're less dependent on how good that doctor is. And I love good doctors, I think they're great. But if I can get a bad doctor to have the same outcome as a good doctor, that's a pretty good day from a healthcare leadership standpoint. Okay, the other thing we learned is we can't just focus on pneumonia and broken bones. Addictions and behavioral health have been ignored by community hospitals and rural health leaders for a long time. It's just seems like an insurmountable problem. We couldn't get psychologists and psychiatrists to work in our areas, so we kind of turned our back to it, and I was no different. When we started getting into population health, we realized the patients we could not move forward or advance were the ones that had big behavioral health or addictions issues. We started a program for addictions in our area because in our community needs assessment, it was the #1 issue. And if you read the Atlantic magazine or have heard of it, our program and our leader of that program are going to be highlighted in that coming up in April or May. But a lot of the things that kind of came from that are what we've learned. And we've had a very successful program. If you think about addiction successful treatments, outpatient, usually successful is somewhere around 5 to 10%. How many patients go through that and are successful breaking their addictions? Our success has been much, much higher than that. It's been in the 70% range. One of the things we've learned, and there's a lot of reasons behind that. It's not because the hospital has a great CEO, I will tell you that. I'm not the reason behind that. It's a good team and we work together with the court systems and a lot of local agencies to really make a difference for these folks. But one thing we've learned in the patients that are coming through the addictions is they were abused as children. Some of you may know what an ACE score is, an adverse childhood experience, but these were kids that had separated homes, their parents were incarcerated. There's a list of 10 things on an ACE score, adverse childhood experience score, and if you've got 4 of them or more, then these are the statistics that run with it. You're much higher depression, 1,200% higher chance of committing suicide, 20 years shorter lifespan. What we found out with these folks that we've run through from an addiction standpoint is really that their childhood was rough. The median score for our patients that are in the program is 8 out of 10. These are statistics for 4 out of 10. We've had 70 patients roll through that program. What's really been interesting is the childhood trauma, the patients have a much higher acuity, but the success rate's been better. Some of the things that I've learned from working with these patients is they think nobody cares about them. They think they've been thrown away by society. And they're primarily in their late teens, 20s, 30s, but we've got older patients as well. We do a lot with peer recovery coaching, people that have been right where they are, and there's some point halfway through or 3/4 of the way through the 8-month program that we put them through that they start thinking that they could have a life without addictions. And they start caring about themselves. Moreover, one thing we've seen is they care about each other. And their empathy drive kicks in like I've really never seen. Half of them become vegetarian because they're caring about people and every animal on the planet. I've seen them live paycheck to paycheck and then give their paycheck to somebody that they think needs it more. It's this really interesting empathy drive. That I haven't seen anything else, but I think there's a lot of that goes on. The key to our success has been some of this partnerships. Dietitians, we'll bring food in, they've got such food insecurity, we bring the celery that's left over from a previous meeting and it'll be gone. The celery, who goes to a meeting where all the celery is gone? And one poor guy, I remember talking to him, And they talk about things they want to look forward to. What do you have to look forward to? And his statement is he'd always heard that salmon tasted good, but he'd never had it. So all through his treatment, he's never been able to afford it. But he's collecting recipes for how to cook salmon. And one day he's going to buy salmon and cook salmon. I sure hope he likes it. Oh my gosh. Heaven forbid he's allergic to it. But that's what he's looking forward to. That's a big deal. And it's getting people to look forward to some things. So we work closely with the judges, the court system, OB programs. If you test positive when you're pregnant, you're automatically enrolled into this program. And it's a carrot and stick. It's 13 hours to 15 hours a week. We drug test people 3 to 5 times a week with random drug testing. You miss and you were court ordered there by the judge, you go back to jail. You're a mom and you miss, you end up, we've got 96% attendance rate at group therapy. I mean, it's really, really quite interesting. Our dietitians have become very big on this. But this is what we can do in small town America. We can gather these folks together and we can all work together because we are taking care of us. It's not us and them or anything like that. This is us. Our people, our folks at the hospital went to high school with these folks. They know who they are. They know their challenges. That's one of the things that in an urban environment, there's a we and them type of thing. In a rural area, it's all us. And we kind of know that. Electronic health records. Okay, students or healthcare professionals, how many have to document on an electronic health record? Okay, explain to the rest of these folks how difficult this thing is. We had to do a conversion of ours from one system to another. I was the least liked person in Batesville. We had to do a conversion during spring break. I canceled spring break. You want to talk about people disliking me. It really undermines your entire organization. So when you go through that in a rural area, and that's one of the things, a lot of the rural hospitals are facing significant challenges, significant financial challenges, but many have not converted electronic health records. And that's something hanging out there that's a big deal. I won't go into this one too much, but I will tell you, some of my colleagues, some hospital CEOs are scoundrels and rascals. Some may describe me as that, but they're not all evil. Contrary, also, physicians are not all by definition the greatest folks out there. And you just have to realize that. The solution to the challenges we face in healthcare won't come from one side or the other. It's from all of us working together. Hospital boards, I won't go into this a whole lot, but it's one of the real challenges out there. You've got people that are on a hospital board that don't have a healthcare background, they don't understand that. They're just good people that want to work in the community. Anybody FFA, parliamentary procedure? Okay, raise your hands up. Okay, the people with their hands up, ask them, they've been trained on how to bring a diverse group of people together and come up with a solution at the end of it. And there's a process for that, and it's a big deal. Most boards are not trained very well in that, and they just sit and circle around some of these issues. And I've got a lot of single-issue board members and a lot of board members that just want to be there to make sure their enemy gets fired or their friend gets hired. Big thing I will tell you, if you're interested in healthcare leadership, is create a network. Find out people that are working in the world of healthcare and find the people that will be honest with you. Be the ones that will be honest about their failures as well as their successes. I know a lot of my colleagues will stand up in front and they'll brag about what they do well, but they won't tell you what they're failing at. And we need to be honest with that. There's a lot of challenges, and again, most of the stuff I've learned through failing. But that's where we are. We're at a point of honesty where we need to be straightforward, and this is what's going on. Healthcare is the most complex field out there. We send people into harm's way. We end up dealing with life and death situations. We don't know how we're going to get paid. Sometimes we don't get paid at all.
This is planned. Can I ask you to spend your last 5 minutes talking a little bit about how your hospital is getting ready for the coronavirus?
And that's my next point. And last point, evidently. One thing we don't talk about too much, and I'm glad we've got a lot of students in here, is healthcare is a mission, it's a calling. We end up having to go in and care for patients with infectious diseases when for the most part we know how they're transmitted and we know how to protect people, but as people are running away from a fire, our staff have to run toward it. I've got nurses' aides and medical assistants and students and people making less than $15 an hour that are going to have to come into this situation. And this is the one, the COVID-19, that I'm worried about. And leave their families and take care of people who are infectious when they've got no protection. And usually we're big on influenza vaccines and everything we can to protect them. They've got no natural immunity to it whatsoever. There's a lot to be concerned about this. Now, granted, as a hospital CEO, I have to prepare for the worst. A bad flu year, the mortality rate will be 0.1%. The COVID is somewhere, depending on WHO or the Chinese data, is somewhere between 0.7 and 2% mortality rate. It affects mainly older folks. The kids haven't been affected by it as much. And when we face this, if it's as bad as what we fear, we're going to have many of our healthcare workers out with it when we need them the most. This is something that we haven't faced, and I remember I worked early on with AIDS patients, and I'd see people that would gown up and go in and take care of those folks regardless of their own, because that's what we do in healthcare. We're called to take care of people, we're called to make a difference, and it's an important calling. This one bothers me a lot. We'll end up doing a lot of backroom preparation. I mentioned Batesville Casket and their strong epidemiology team. I will be working with them very closely to try and understand what's happening. We've got some good things going on from the standpoint of it's spring, and if we get as mild a spring as we had a winter, then we've got the possibility of being able to get out of this and learn a little bit more about it as we see it progress in New Zealand and Australia as they go into their winter season and what we can do. The Surgeon General came out, don't wear masks, they don't help. Wash your hands, cover your cough. That's a big deal with this. If someone walks in and sneezes on this table 30 minutes before I got here and I step and put my hand on it, all right, it's on my hand. If I touch my face, all of a sudden there's a possibility that it's contracted that way. So it's not about masks as much as it is about good, normal hygiene and things of that nature. So it's something that's worrisome. We face SARS, we face MERS, Ebola as possibilities. This one's clearly in the US and expanding, but it seems to be declining in China. Our problem is with a lot of the things with China and many countries around the world, we're not getting the accurate information. It's coming through a regime and we're getting fragmented information. That's the pitch. I'd like the world to work together, but it's really important the US healthcare system work together and function on this. So that's one of the challenges that I've got to deal with COVID-19. I know I've got a couple of minutes, but one thing I'll tell you is the world of rural healthcare, I think, is the most rewarding profession out there. We get a chance to be healthcare professionals and make a difference for folks that we see on a regular basis, that we're going to see day after day after day. My friends in the urban environment are really good at what they do, but they're practicing a profession. They're making a difference for people, but I'm making a difference for my friends and neighbors and family. And that you cannot get very many places. It's a worthy profession. I realize I'm running out of time, but I'm glad to take a couple of questions, or if I don't have any time, then I'll be hanging out in the hallway.
We're going to get you to the radio.
Okay.
And, we have an appointment downtown, so.
That is the world of rural healthcare as I've seen it in my last 17 years, and I appreciate the opportunity to be able to speak with you guys today. Thank you.